From BCP, can I nominate Laura Miller, please? Councillor Laura Miller, sorry. Have I got a seconder? I'm sure I will have.
Yes, Councillor Graham Carr-Jones.
Oh, yes, a chorus of seconding, David, so.
Thank you.
Thank you. Well, in the absence of any other nominations, Councillor Miller, Chairman for the meeting.
Thank you, David. Right, let's have a go at this then, shall we? So thank you all for coming. Absolutely great to see all your lovely faces. We need to next appoint a vice chairman from our BCP colleagues. Do I have a nomination for the vice chair position, please?
Well, I'll nominate Leslie. Shall I? Councillor Leslie Dedman.
Fantastic. And the seconder?
Second,
Excellent. Gosh, that was a moment there, wasn't it? Right, apologies, David. I don't think we've got any apologies.
I think Jan Thurgood is not able to come. I don't know if she's an apology because she's in the same meeting that Sam just left.
Okay, so I imagine that goes for Vivian too.
But no formal apologies in terms of elected members.
No.
Okay, fantastic. Thank you. Right, to confirm the minutes, have you all had a read of the minutes from the 3rd of February? Gosh, that seems like a long time ago. I'm just going through the minutes. I'm not sure if there were any matters arising that don't come up. I think everything does come up that we need to talk about. Does anyone have anything they'd like to raise from the minutes on the 3rd of February, or can we take them as an accurate record?
take them as an accurate record, Chairman. Chairman, who is watching the chat bar? Who's monitoring the chat bar?
I am.
Okay, so
I imagine David is as well.
It's very difficult to chair and monitor, so whether your vice chair, just because I flip from the participants to the meeting chat.
Okay, I've got both on my
See
screen.
who's raising whose hand if you've got the meeting chat on.
Yeah.
Okay, well in that case, that's a good point. But if I look at the chat bar, instead of raising your hand, can you just type RTS, right to speak, in the chat bar, and then I'll be able to see it in the same place. Hi Lucy, Sam, thank you, that's really helpful. So let's move on. We take those minutes as an accurate record. Obviously I can't sign them, but I will do when I can, if I have to. Let's move on to the forward plan. Sam, is there anything that you want to raise with the forward plan? I'm just looking and everything comes up okay for today, and then we move forward to November. Quite a lot on the November agenda.
Yeah, so I'm just having a refresher and a reminder of this. I think our business has been interrupted quite a lot because of the pandemic. So we were sort of sailing along quite happily in February. We have had to postpone the partnership agreement, formal agreement, until the November board, which is why it's shown on the forward plan for November. And we've also got some timescales to meet for our retender of drug and alcohol, which we'll talk about today. I think probably the other issue we need to look at in terms of the business plan monitoring is our sort of strategy going forward, which I'll talk about under my update. How it's feeling at the moment is that the business plan that we regularly monitor through the board is having to be reprioritised and changed quite a bit because of the focus on outbreak management plan work, which is taking precedence at the moment. So I'm hoping in November we'll have a better, clearer view of what work's likely to be achieved by the public health team in this financial year, and what are we having to set aside just because we're having to split our capacity quite significantly at the moment. So yeah, November board feels as if it's going to be fairly action-packed, but we've got some decisions that we need to take then. So this is very much, I guess, a bit of a warm-up meeting in part today, just to get the board going again and to keep members updated as to where we are.
Okay, fantastic.
That's all, thank you.
Thanks, Sam. Graham, you wanted to speak.
Unless I missed it, Chairman, did we skip declarations of interest and public participation?
We did, yeah.
Perfect.
Should we go back?
No, I don't know. Just
Thank you, much appreciated. Yes.
Yeah, we did totally. It's my fault. I skipped on the left-hand bit of my PDF.
It's really difficult because I'm trying to read the agenda off an iPhone and look at all you lovely people.
It's all right. That's absolutely right, Graham. Completely right. Should we do that now, David? I do apologise. Anyone got any declarations of interest?
No.
No. Anybody? Thank you. Do raise them as we go along if you do, any do come up. That would be great. Public participation, and if there are members of the public and we've got questions or town and parish councils, then I sincerely apologise for missing you off. I do apologise. David?
Chairman, I can confirm we have had no such responses or submissions.
That's absolutely outrageous, and I missed them off and everything. I was hoping there'd be someone disgruntled that I could I could invite in and apologise to. Never mind. Let's scroll back to the agenda then. So we go into, and let's just double check that I've got this right. So we've received, considered the forward plan. Thank you, Sam. I think we're all on board with what looks to me be quite a meaty meeting in November. And now I think you're going to give us a verbal outbreak on the a verbal update on the local outbreak management plan.
Unmute your mic, please, Sam.
Right, that's better. I still haven't mastered the art of sharing my screen in Teams and being able to find the mute button. I'm going to have to leave your lovely visages for now while I go to the PowerPoint myself so I can see it. But I've just prepared a few slides that I hope will cover my updates. Just before we get into the update on local outbreak management plans, I thought it might be quite helpful to share this slide that I developed for a couple of meetings last week. This is data that's been taken from the National SITREP, which shows the cumulative incidence rate of COVID cases at a national level. So this was the situation last week, and you can see council by council, those incidence rates have been mapped, and you can see it's quite striking, the pattern of how COVID's affected the northern metropolitan areas in particular and cities. And you've got this band of COVID infection rates being much, much higher, sweeping from the northwest. We got off very, very lightly, so you can see that incidence rates remain the lowest of any of the council areas in the country for both Dorset and BCP Council. But a bit of a note of caution, if you look at Hampshire's experience, has been a little bit different. They've had higher infection rates. And on the current list of council areas of concern, Folkestone and Hythe are starting to pop up as one of the southern areas where they're now experiencing higher infection rates. But overall, we've done very well with a low number of cases in both council areas. Just some data that's emerging on outcomes and poorer outcomes and groups most likely to be affected. Black and minority ethnic groups, much more at risk of poor outcomes. And there's also a cluster of health conditions which are linked with poorer outcomes from having COVID, diabetes, being older, being male, and occupations as well, emerging as key risks. So people in high contact occupations, so transport workers, care home support workers, all of those have emerged in the national analysis as being linked with a higher risk of poor outcomes. Enhanced surveillance is going to be really important over the next few weeks and months, and we're already starting to think about winter planning, and not just the return of COVID-19, which experts are predicting may well happen, because once we all get into the colder weather and more people spend more time indoors, that obviously increases the risks of transmission. But increasingly, we're starting to think about what the seasonal flu campaign will look like this winter, likely to be extended to more groups than we normally immunise. And the planning for that is starting to happen in the Dorset system already. And on the National Risk Register, I thought it was also worth highlighting that although we're thinking about lots of weird and wonderful settings for outbreaks, actually care homes continue to be the setting of highest concern. And if you look at the number of active outbreaks in the National SITREP at the moment, there are very few outbreaks in schools. Most outbreaks are connected with domestic residences and families, and the next highest group is still care homes at 15% currently. So just a little bit about outbreak management. This is a responsibility now of both new unitary councils, and on the 30th of June we had to publish our local outbreak management plan. We had the delight of producing 2 plans for our 2 councils. So there are similarities because we used a similar framework to develop the plan for each council. But it's important that this isn't just thought of as we've got to the 30th of June, we've published the plan, and now we can sit back and relax. Actually, it's just the first stage. So we've had to stand up a new COVID-19 Health Protection Board under local outbreak management plan work. That's a single board which works across both councils, and I think we've had 3 or 4 meetings now. We've got really, really good engagement from key officers that are going to be crucial to our response as we start to think through what we have to think about in terms of our high risk settings. So we've got representatives from regulatory services officers that support ports and borders. We've got some great EHO colleagues supporting the work, thinking through how we would respond in food manufacturing settings. We've got great support from colleagues in housing, thinking through some of the issues with supporting vulnerable residents, people who live in houses of multiple occupation. All of those present particular challenges and risks that we have to think through when we're developing these action cards about how councils will support the public health response. Also in the guidance was this important role for local outbreak engagement, and these are leader-led boards that are going to operate through each health and wellbeing board. So what we've done is gone to the 2 health and wellbeing boards, taken extraordinary papers on the local outbreak control plan, but also made a recommendation that the health and wellbeing board would be able to stand up a local outbreak engagement board very quickly if we have to respond and start to do comms in a hurry. And as a minimum, that would be leader, chair of the Health and Wellbeing Board in the case of Dorset, chief executive of the council, director of public health, and a CCG rep as well. So that was supported by both boards, and it feels like we're in a good place now in terms of getting our governance straight and our lines clear. I think what we know from the evidence is the importance of good relationships, and as a system we've worked really, really well during the first phase of the pandemic. So the way that the Local Resilience Forum worked, the Gold Command group that was brought together, where all the multi-agency partners came together to develop the strategy, has worked really, really well. That's the group that may well need to be stood up if we get into a situation where we're needing to perhaps invoke some of the national powers rather than the powers that councils have to respond to outbreaks. The final bit on this slide is just to note that MHCLG have provided each council with a test and trace grant, which is non-recurrent, to support outbreak management plan work, and that's worth 1.28 million for Dorset Council and 1.8 million for BCP Council. And we're working through the Health Protection Board just to start to develop a resourcing and capacity plan. We're not intending to spend that money by any means all at once. Some of it is required now to support training and development and communications work, but the majority of it we're hoping to hold in reserve in case we have to pull on some fairly weighty resources in a crisis should we need it. So just to sort of say that this is the kind of framework which is emerging now under each outbreak management plan. We're thinking about work at 3 levels. Level 1 is where we are at the moment, which is just very much day-to-day outbreak response. This is work that we know what to do. It's the bread and butter work of the Public Health England Regional Health Protection Team. So if we get an outbreak notification of something happening in a care home, for example, or a school, we're pretty well drilled in who contacts who, what are the supportive actions that we would put in place around that organisation. Some of the training and the development is already well underway. We've done lots of infection prevention and control training in the system, but that's likely to go on for some time, particularly as we start to look at some of the settings like businesses, hospitality and tourism that are now opening up and obviously starting to attract lots of visitors. Level 2 is where we might have several outbreaks and there's potential for wider spread into the community. So usually what happens is we think it's relatively well contained. You start to do the contact tracing, and as a result of those interviews, you then start to realise that actually you've had spread into families and households beyond just the setting. So it starts to look as if you've got a number of clusters of cases connected with those settings. That might start to look as if we're needing to call on multi-agency partners to support. So, for example, if we needed to generate a big infection prevention and control response, we would have to work with the CCG very quickly. We might have to do that through the Gold Command Group that I mentioned earlier. And then the final level is a level we hope we would never get to, which is a local outbreak that has national significance. And that would be most likely to be a sustained rise in community cases, exceeding a number of triggers. One of the triggers that they're looking at in national terms is your testing positivity rate. So if it starts to rise above 5%, that's a concern. But the real trigger of concern is this 7-day case incidence rate. So this is the number of COVID cases per 100,000 population in a 7-day period. And if that gets above 50 in a 7-day period, then we'd be in quite a serious situation. But just to put that into context, both councils roughly have a population of around 400,000. So you'd be looking at 200 cases in each council over a 7-day period. And we've never been anywhere near that, fortunately. But that just shows you where places like Leicester are at the moment, because that's the type of situation they're facing at the moment. So just a final slide from me on outbreak management, just to say next steps are regional and local assurance around the readiness of the plans. So this involves exercising some of the action cards related to the highest risk settings. That work's all going on at the moment through the Health Protection Board, but also making sure we've got a good resourcing and capacity plan in place. As I mentioned in the forward plan discussion, we are reshaping the Public Health Dorset business plan and reprioritising it into 2 work streams. So one is labelled recovery, which is our business as usual public health work. We're doing a lot of support through Live Well Dorset, looking at the new demand that's coming in for smoking cessation, which has been a real boost since we entered the pandemic, and looking at the response side, which is very much what I've just described. So outbreak preparedness and how we would respond if we get into a situation where we need to surge very quickly. I think the capacity and the resourcing within the public health team feels about right. Probably we'll make short-term investments from the Test and Trace grant in our ability to carry out modelling to backfill environmental health officer support from both councils. We're looking at continuing to support the helplines that were stood up to support people who are shielding. So we've had discussions with both councils about the sort of support the Test and Trace grant could give to that. And that's really key for me, because the sort of reach that we've had through the work with the voluntary and community sector is really important. If we're going to take a community engagement and public assurance approach to outbreak management, we can very quickly reach into those communities and work with those organisations to get the key messages out, rather than looking at an enforcement route. And I'll just pause there, if I may, because the next verbal update is the update on the partnership agreement. So if anyone's got questions or comments, I'm happy to pick them up now.
That's fantastic. And I think, I mean, I've just found that verbal update in your presentation incredibly reassuring, because I think, you know, the detail and our situation in Dorset, you know, it is reassuring. And I completely agree with your point about using our voluntary community sector colleagues, because we have got that outreach, haven't we? and it would be silly not to use that. And I think also that plays into the point about reassurance, because we have been able to reassure so many of our residents through all our partnership working that if we can continue to use those channels, it will be helpful. So I have Leslie, you would like to speak.
Yes, thanks, Chairman. Yes, Sam, you said quite early on that in the winter pressures would include more risk because we're spending more time indoors. Why is it more risky to spend more time indoors? I thought we'd been locked in indoors.
Yes. So as long as we're locked in and we're in separate households, that was the public health intervention we had to take just to break the chain of transmission. But at that point, we already had lots and lots of people in the community with COVID. So it was really crucial that we went in and didn't mix with other households. I think the concern is always that when we've been out and about all summer, and then people start to get back into indoor environments, if social distancing isn't being maintained, and if we've opened up and we're in recovery sufficiently that lots and lots of groups have been mixing, then that's a situation where if you've got 1 or 2 cases of COVID in your social network, if you're indoors, then the chance of transmission through droplet spread is very, very much greater than if you're outdoors, where actually the wind, UV, ultraviolet radiation means that the virus doesn't survive as long outdoors. So the risk tends to be higher indoors, and that's what a lot of the studies have shown when they've looked at poor circulation in indoor environments is a great way of making sure that you're recirculating those droplets and you can have an increased risk of transmission. That's all that means, but it's national modelling. Doesn't necessarily mean it's going to happen to everyone in their own domestic environment, but it just increases the chance. You classically see it with schools in September when everyone comes back, and that's when you see that sort of spike in childhood illnesses.
Yeah, absolutely. Sandra, Councillor Moore, Sandra, you'd like to come in?
Yeah, thank you, Chair. Yeah, all the business about the track and trace and getting the app on your phone and everything else. My phone's been geared up to have it, but I haven't got one yet. No. I don't think anyone else has either. And all the the contact tracing, you're going to end up going door to door if we're all doing it locally, aren't you? In order to be effective. And I just wondered, manpower and all the rest of it. It's all a bit confusing for me.
Perhaps it'd be helpful, and I know Councillor Carr-Jones has made the point in the sidebar as well. If I perhaps explain how this fits together a bit, hopefully you'll be a bit more reassured. So there is a national test and trace system. They didn't go with the app in the end, although I'm reliably informed that might make an appearance by Christmas. I'm actually more reassured that they've gone for a telephone-based contact tracing system rather than something that was relatively unproven. So the core of the NHS test and trace system, they're trying to get a single door into the service so that as many people as possible are tested via test and trace. So there's 2 ways in. There's you can call the number 119, or you can go via the government portal, which is the Pillar 2 testing, which is for anyone in any group that isn't connected with a healthcare setting effectively. Goes through that Pillar 2 testing route. They then deal with those cases at 3 levels. So the bottom level is call handlers that are recruited from the private sector, by private sector contractors within NHS Test and Trace. They all work to standard scripts. They're fairly straightforward telephone discussions just to check that people have got their test, and then they start to go through a very basic contact tracing interview with that person, just to try to find out what they've been doing, who they've been with. If there's anything of concern flagged in that interview, it gets bounced up to the next tier, who are largely health professionals. So they're used to contact tracing, they've got an enhanced level of training. They may well do a more in-depth case interview with those people who've tested positive. And then the third tier is if there are any links at all with people who work in complex settings or high-risk settings like care homes or schools, that gets bounced back to the regional Public Health England health protection team. So that's the team that I work really closely with. And if there were anything on our patch that was flagged through test and trace, they would ring me straight away and they'd say, we're concerned about this cluster of cases we've picked up. We would discuss actions. I'm now able to see that personal level information because we've got a data sharing agreement back with Public Health England, which wasn't in place a few weeks ago. So the system's starting to come together in a more coherent way. But going back to your point about whether we'd have to do this locally, I think the only situation where we would have to stand up local door-to-door contact tracing would be if we were in a very, very difficult community outbreak, in which case we'd be drawing very, very heavily on public health teams from across the area. We've already had discussions with neighbouring public health teams and we could mobilise that sort of surge capacity. We've also got people who understand how to do case interviews and contact tracing working in sexual health services. We could also look at the public health nursing service locally with health visitors who are well used to working in communities with families to do that sort of work. So we hope we'd never get to that stage and that most of it will be done by test and trace. But we have got that ability to stand that up if we get to that situation.
Brilliant, thank you, Sam. Graham.
Thanks. Sam, am I allowed to be sceptical and controversial?
Good Lord, Graham, never.
I mean, I don't understand, and I really don't understand. In the beginning, when I first took on the role of community as whatever it is, when we built the temporary morgue up at the radio station, we started planning for 3,000 excess deaths. Then we started planning for 6,000 excess deaths. We didn't see those. We've seen the schools have not gone back to school, and yet we've seen our beaches and public areas mobbed by people. We've had protests by young people and students all across the country, and I haven't seen the increase in numbers. And I'm just, I don't get it. I really, does anyone really know, or are we all just, sort of just going, well, it could be this, it could be that? What's frightening is that no one really knows, and everyone's coming out with all this stuff and actually not seeing what we're being predicted. Now, if it's just a way of controlling us to make us be good and stay indoors, perhaps that's what they're doing. I don't know. I don't get it.
Okay. Lots in that question. So I'll go back to when in February, when we first started getting the national modelling through, it was called Reasonable Worst Case Scenario Modelling, RWCS, and that's exactly what it says on the tin. So those estimates of mortality are basically saying there's a pathogen with potential pandemic potential unleashed in the population. And if we do nothing, this is the reasonable worst case scenario. So those projections of 4,000 and 6,000 came from the modelers who were advising government to say, if we do nothing, that could be where we end up. Fortunately, we didn't do nothing. And that was where the social distancing measures and then lockdown came in, and we managed to break the chain of transmission. But if you look at online, some of the debates are effectively criticising the government for not acting quickly enough. So one of the statements that's been made is, had we acted a week earlier, we could have avoided 20,000 deaths. And that's because of the transmission dynamics at the time. We were surging so quickly and so rapidly that the government was criticised for waiting a week. And it wasn't until March the 23rd that they suddenly said, right, everyone indoors, we've got to hit this really, really hard. So there are scientists that say, had we done that a week earlier, we may have seen 20,000 fewer deaths nationally. Now, we'll never know, because obviously that hindsight is an amazing thing. But if you look at other places around the world, certainly the United States, I think you see evidence there of a really fragmented system where state by state, they don't have this national power, if you like, to say, this is how we're going to treat coronavirus across the United States. And you're seeing real difficulty getting the pandemic under control there, because different areas have been doing different things. They've had a different approach to using those powers. So I understand the concern, but I think as a public health professional, I'd always say we're damned if we do, and we're damned if we don't. Because had we not done it, we don't know where we might have ended up. And even our experience is one of the worst experiences of any country with coronavirus. The mortality rate has been far higher in the UK than many other countries. You know, we're still at 46,000 deaths, which is a much, much higher figure than many other countries. So it's not something I feel we should have sort of played fast and loose with. The bottom line is there's still a lot of people out there that haven't had it and are susceptible. And that's the concern, because it's far more transmissible than some of the other coronaviruses than we've had before. Do you remember the original SARS outbreak? You had SARS first time around. So the WHO was criticised back then for being really heavy-handed with it, and we limited the number of deaths to around 700. Well, interesting that they were criticised for being heavy-handed and putting that temperature monitoring in at every airport. If we hadn't have done the same thing in this country, we don't know where we would have been. So it's always a balance, isn't it? But hopefully that, I don't know if that helps at all.
Well,
but
well, no, not really, because the problem is that we're being all encouraged to socially distance, which, you know, the sensible ones amongst us will do. But how do we answer the question that thousands and thousands of people got together and protested and marched around one another, and yet we haven't? One would expect, especially given the ethnicity of many of the protesters, I would have expected to see a huge spike in those areas, and it hasn't happened. So,
well, a couple of things
that confuses me.
Yeah, a couple of things. I think when we're looking at the influx of tourists on those hot days, it is quite possible that the circulating levels of coronavirus had already dropped quite a lot. Well, I think what will happen when the look back comes is that people didn't appreciate just how much coronavirus was in the country in February. Everyone was fixated on Wuhan. There were lots of travel restrictions being imposed on flights from Wuhan, but there was virtually nothing from Europe. And we know that Spain had it, Northern Italy had it. People were flying into this country from those parts of Europe quite happily. We weren't tracking and tracing those people at that stage. I think the other issue is we don't know, for example, I don't think the virus is very easily passed outdoors. And I think so the kind of clustering that we've seen around beaches may not be as risky as people might have thought. But lots of those people did travel here in enclosed spaces, whether it's cars or coaches or trains. That's a far more risky environment. And I don't know whether any of the national contact tracing data will show if cases in places like Leicester. I know that lots of people from the Midlands came here during that week when lots of people were on furlough and we had the hot weather. I have no idea whether some of the current problems in Leicester were actually seeded because they travelled to the coast, had a day out, travelled back. We may never know. No, it's very difficult to unpick these things.
My concern was more around London and Bristol and those areas that haven't seen those spikes. And the reason that Spain and Italy were so badly affected is because of they have a huge shoe expo in China, because Spain and Italy are huge shoe producers. They'd all gone over there last year and got it. And that's how it's filtered into Europe. That's my intelligence anyway.
Thanks, Graham.
Quite possibly.
Thank you, Sam. I think that's reassuring. And you know, I'm aware that this is around our own outbreak management plan. So just to draw back to that, thank you for the update. If no one's got any other questions, I think we'll note that and thank you for it. And we'll move on.
Chairman.
Yeah.
Dave Northover. Just one last thing. Sam, as the item was an oral item, there's no report to go with it. So not only members of the board, but the general public haven't as yet had anything to see. what exactly Public Health Dorset has done. So I've found your presentation not only very informative, but it helps in all our understandings of what Public Health Dorset not only has done, but is doing to achieve the relative success it has. So it would be handy if you could let me have that presentation, and maybe I could append it to the minutes, so it's out there as a public record. Would that be?
Yeah, that would be absolutely fine, David. I'd also make the point that both outbreak management plans went through the public health and wellbeing boards, and the plans are on both councils' websites.
Right.
So if you go to the COVID-19 section, there are public
Right.
links to the plans, so we can provide all of that just so that the any of the public that want to look at the work of the board are cited on that.
Thank you very much.
That's really helpful, David. I know it's helpful for all members to have sight of these things, so that as leaders in their local communities, they can answer any questions and reassure people when it comes up outside. Yes. Thank you for that. That's a really helpful point. So the next item on the agenda is the future of the public health agreement. Sam, I think this is another verbal update, but I think you're treating us to another slideshow. Am I right?
Just one slide this
Excellent.
time, you'll be pleased to hear. So literally very quick update on the partnership agreement. As you know, we renewed the terms of reference to the Joint Public Health Board as we were going through local government reorganisation, and we made a clearer separation so that the board's work was more focused on the business plan, the performance of some of the public health services, and was a bit more of a sort of an assurance around delivery type board over what the shared service was doing in support of public health across both councils. And that took us away from perhaps some of the more strategic work of the health and wellbeing boards and the integrated care system. The refreshed partnership agreement has been developed with legal services and Section 151 officers in each council. We were due to take it to Joint Public Health Board, but then the pandemic hit. So it's now scheduled to come back to Joint Public Health Board formally in November, as we saw on the forward plan. There's been a minor amendment to the wording so that I think BCP Council colleagues were quite they were quite supportive of this idea of an annual review of the board's effectiveness to be built into the work programme of the board. So one of the discussions that we'll have in November is just to see whether we feel that the focus that we give throughout the year on looking at each of the sets of public health services, because we take a performance report on clinical services, health improvement services, is that enough of a focus for the board? And then we do an annual report, if you like, looking back on what we've achieved through the business plan and perhaps some of the kind of issues that we've gone through in that year. And then it allows members of the board, I guess, space to comment on our performance as a shared service, and then we can just have that annual review built in. So I'm hoping we'll be able to sign that off in November. There were a couple of comments made by Section 151 officers just to say, how do we future-proof the agreement? For example, before COVID-19, there was discussion nationally that the financing around public health may change. So you remember there were discussions about the public health grant losing the ring fence and perhaps public health being fully funded from retained business rates. I have no idea, now we're in recovery, what the thinking at the centre will be around the future financing of public services. So as we'll hear under the finance paper, we've had a helpful uplift for 2020-2021, but we're still waiting to see further detail around that. But I'd make the point in the partnership agreement finally that irrespective of what it says in the partnership agreement, the agreement still gives all of the parties under the agreement, I think 6 months, or the ability to give notice of 6 months on any contracts. So if we did get to that point where we wanted to do different things, the agreement allows for that.
Fantastic.
Great.
Thank you, Sam. Does anybody have any comments? I think we can all agree that, as you mentioned, having that space to sort of discuss and perhaps challenge and really go through things is really, really helpful. I'm not seeing any right to speaks or hands up. So I think we'll say thank you and note that, and look forward to giving it a good going over in November. I don't think we have to take any further action on that. So moving seamlessly on, as you segued so nicely into the finance report. So is that coming up on the screen? Or are we just looking at it?
I'm just going to share some slides, if that's okay.
That's perfect. Thank you, Sian. Okay, so Sam, are you going to talk us through this?
I was going to pull out a few points. I was going to let Sian present the bulk of the paper. Sian, do you want to go first, and then I'll pick up some points afterwards? Would that be?
Yeah, that's great. Thank you. So hopefully you can see the 1920 position on the slides there. So just to pick up that the final 1920 outturn for the shared service budget was a total underspend of £170,000. As Sam just mentioned, the spending round in 2019 announced a real terms increase in the 2021 public health grant. This resulted in an increase of £900,000 for Dorset Council and a £412,000 increase for Bournemouth, Christchurch and Poole, giving a total shared service budget for 2021 of £28,748,000. The Public Health have recognised that both councils are facing financial challenges through this time of COVID, and have agreed that any cost pressures identified relating to the COVID-19 would be funded through the grant uplift. So the current forecast outturn for 2021 is a forecast underspend of 177,368 underspend, but these are currently very provisional figures at this stage of the year, so those will be confirmed throughout the year. Included in this are a number of non-COVID and COVID-related cost pressures, including things such as the increased demand on the drugs and alcohol service through COVID and non-COVID related demand, agenda for change uplifts, increases in sexual health services, health improvement within smoking, suicide and bereavement support through the period, modelling and data science, and systems mental health support. And then finally, there's £617,000 of reserves which have been agreed for prevention at scale. For 2021, there is an uncommitted reserve of £293,600. This is lower than the expected £500,000 that was reported last year, but that's due to the planned returned funds back to the local authorities in 1920. And then the recommendation is just that the Joint Public Health Board note this paper.
Brilliant, thank you, Sian. That's really helpful.
Thank you.
Sam, I've got a question from Graham, but Sam, did you want to draw anything out before we go to questions and debate?
Thank you, Chair. I think Sian's actually picked up on most of the points. I'd make the general point that at the moment our budget is moving quite a lot. So as Sian highlighted, in the early stages of the pandemic, we had to change how a lot of our face-to-face public health services were delivered. We built up some cost pressures around those services that had to work differently. We probably won't know the true position until sort of further on in the year. We're still negotiating with some of our suppliers, particularly around community public health services, around exactly what we do in terms of support to those suppliers. We're working through the commercial cell at Dorset Council so that we're not setting any different precedents to how we would treat any other suppliers. But it's fair to say that some of those suppliers aren't happy that we perhaps haven't been as financially generous as some other councils with that support. I think the outlook is fairly unknown. The test and trace grant that we've had to support our response work is helpful, but it's non-recurrent, and we need to sort of use that grant quite carefully because we'll never get it again. So we're not intending to spend it as part of our core public health budget, but it is held there in case we need to bring in capacity at short notice. So the only other point I was going to make for the board is that at some point we'll need to revisit the future of the prevention at scale work. Sian mentioned the committed reserves against prevention at scale. I've been making the point to partners that it's unlikely that we would be in a position in both councils to be able to have further finances to support this. We never saw the prevention at scale programme as a sort of commissioning programme, but we did want to invest in developing a number of tools and platforms to enable partners in the system to be able to carry out prevention interventions. So our future prevention strategies much more likely to be embedded within transformation programmes of each council. And as such, the integrated care system is also starting to think through how its future work will change post-COVID. And one of the programmes that we're supporting quite strongly is this population health management work, which is giving primary care networks a much better view of some of the people most at risk. And I think that's where we'll see the bulk of the prevention at scale strategy being focused over the next couple of years. So that was all I wanted to say, really.
Thank you, Sam. I think that's really helpful about the prevention at scale work, and the more we can sort of get the ICS involved with that work that has been started is great. Graham, you wanted to ask a question or make a point.
Sian, I have never found such a confusing budget. Maybe it's designed that way. I really, there are eye-watering numbers in here, and when I see underspend, it always rings alarm bells to me, because if we budgeted and some, you know, I don't want an overspend, but if I'm underspending, it indicates to me potentially that I'm not delivering in some area or service. Am I right in thinking that? I couldn't get to the figures, but I think maybe now I've realised. Now I've got the other figures in front of me. I understand that it's gone from 19 million or whatever. They're in the millions rather than the hundreds of thousands. So I was struggling to get those numbers up, because and with the Bournemouth one, I kept on getting it to 413, not 412. But that could be me being good at maths as well.
Yeah, it's probably roundings with those ones. Yeah.
And I suppose just who scrutinises this budget? That's the ultimate question. Is it down to us 4 members to scrutinise this budget? Because if it is, I don't know that I'm completely content with that. There's just, but I don't really understand this budget, and that's, maybe you can help me.
Okay, fair enough, Graham. I think we all feel a bit like that sometimes. Sam, do you want to give some clarity?
I'll try my best.
Thanks.
So there's quite a few points in there which I'll try to address, so I can't get my hand down now. So in terms of the big numbers, the public health budget is largely constructed of budgets for public health services that we commission, which is where some of those large numbers come in. So if you look at the 11 million or so for children's public health nursing, it's a single contract. We've also got large single contracts for sexual health services, and we've got fairly large numbers against the drug and alcohol services that we commission. And then they start to get a bit smaller. So under health improvement services, we've got a budget line of less than £1 million for the Live Well Dorset service, and then a number of what we call community public health services that are commissioned from GP and pharmacy providers. And then we've got the staff budget, and that's largely it. The complexity comes because of the way the grant comes into 2 councils. So the grant is awarded to each upper tier council, and it comes across as a big lump of money into each council. And then under the partnership agreement, we agree how much gets paid into the shared service and how much is kept back, if you like, by the partner councils. So it's always worth remembering that those amounts are slightly different across the 2 councils. They've been different for a long time. We're quite comfortable with that, having gone through local government reorganisation, because one of the positives that's come out after LGR, you mentioned scrutiny quite rightly, we've got more transparency, I think, about having those figures within the way that Dorset Council Finance team prepare our budget, whereas previously it had been a bit less transparent about how that remaining money was dealt with within each council. So coming back to the point about scrutiny, I think scrutiny happens in two ways. I think each Section 151 officer is responsible for understanding how the grant is used. So I have to sign an annual return every year alongside Aidan Dunn and Adam Richins for both councils that basically says, to the best of our knowledge, we're comfortable that the money that comes in from the public health grant has been used against the criteria that set out how the grant needs to be spent. So that's the first level of scrutiny. Public Health England then look at that return and we get queries. So if any of that money is unclearly allocated, I get an email from the Regional Director of Public Health that basically says, what's going on? Can you explain this? So there's a bit of belt and braces nationally. But I also would say the third tier of scrutiny is the Joint Public Health Board. So as members, you absolutely have the right to question this budget and pick over it, try to understand it, challenge us as to whether you think we're using it in the best possible sense. The only point I'd make is that we don't have a lot of room for manoeuvre, and that's where the issue of reserves has probably come in, because we were required to make savings from 2015 onwards in public health services. So this was a national requirement to return about 3 to 4% each year. And the only way we were able to do that reliably was by recommissioning and taking the money out once every 3 years when we relet some of the contracts around services. And that's why reserves built up, because we'd have to do it once every 3 years, and you'd then have much less spend for the following years coming in. So I don't think it's a case of not using the budget effectively or efficiently. It was that because we were doing it through re-procurement of services, we would always have surplus build up once we'd let that lower value contract. I think coming in with an underspend of 170,000 on a 30 million budget is actually a relatively small percentage. And I think it's probably prudent to keep a little bit in reserve just in case we have to have something to be able to account for movement within the budget in year. And that was the recommendation we took through the board a couple of meetings ago, where we said we'd prefer to have around 500,000 reserve just for that contingency. So hopefully that whistle stop tour has helped.
Yeah, I think it has helped be a little bit less confused. But I think that in terms of scrutinising the big numbers, I don't think it's not something that either council actually gets involved in, is it? It doesn't sound like it. Well,
the board always sees the papers that are prepared to in advance of any tender. So we normally go through a sort of fairly set process where we would work up a series of options, and then there would be a business case. The Joint Public Health Board always sees those papers. So board members have the opportunity to challenge and test the commissioning strategy along the way. And that's the opportunity to start to say, do we think that those options represent the best value for money? We're going to go on to talk about the drug and alcohol commissioning shortly, and I'm sure Will might pick up on some elements of that process as we start to talk through that paper. So if you want to have a go at it, I'm happy with that, and in what you're saying, and I'm content. Great. You'll get your chance in the run-up to the re-tender of drug and alcohol services in a couple of years' time, where we're looking at reshaping that potentially across both councils.
Okay.
Thank you both. I think that's really helpful to raise it, Graham, actually, because quite often, enormous budgets make your head swim, and I think just the opportunity to pick out a few bits and work out how we scrutinise as we go, as Sam said, on those, as the tenders come up and as the business cases come up, we really, we're in effect, we're always scrutinising, which I think is quite helpful. Okay, so that's for noting. I think we've noted it. I don't think anybody else has asked to speak on this one. So now I'm very much hoping that we are being joined by Will. There you are, Will. Hello. Will Haydock is going to talk us through the next item, which is the extension of drug and alcohol contracts. So we've got a couple of recommendations on this, and I'll let Will talk through, and then we'll have a discussion, and then we'll look at the recommendations to extend contracts. Will, do you want to talk us through this one, please?
Yeah, I think it's probably easiest if we sort of take this in two parts. So we think about Dorset Council side and then BCP Council side, because they are slightly different situations for sort of obvious reasons, really, once we get into it. So we're really talking about contracts that were awarded in 2017 and had a go live date of the 1st of November 2017. So at that point, we were sort of trying to anticipate exactly what LGR might look like. And we had an opportunity in Dorset to have an integrated service. So what we have in Dorset is one core community substance misuse treatment service. So this is one contract that covers all ages, so both young people and adults, and all substances, so whether you're seeking support for alcohol or any other drug, and a lot of our time is spent on the drugs that are probably causing the most harm in communities, so primarily heroin and a little bit of support for crack cocaine, although that's not particularly prevalent in Dorset. So the situation we have for the Dorset Council area is that one integrated service, quite straightforward. Obviously, there have been the usual sort of commissioning and contracting challenges in mobilising that and managing it, but performance is generally reasonably strong, and we've got through that kind of initial period of sort of staff restructure and working out priorities and ensuring that all staff are on board with that. The original model for these contracts was 3 years with the option to extend for a further 2, either one by one or in one chunk. The 3 years comes to an end at the end of October this year, so we're really seeking that kind of confirmation that it's okay to extend for the additional 2 years we have in that contract. I have no major concerns with that contract. There's no major issues in terms of the design of the service or the kind of footprint of the service. What we have is effectively a Dorset Council footprint. And you can see from the data that we've included that things have stayed relatively stable in terms of the numbers of people that we've engaged for different substances. There's a chart on page 4 that covers that. And there's a chart that covers the Pan Dorset numbers actually on page 5, which shows that we're probably getting dosages better in terms of medication and keeping them in line with guidance, although that's largely driven by changes in BCP, which I'll come on to in a sec. There are still some challenges in the contract, particularly around premises in Weymouth. Weymouth is our area of highest need, and a 30-year lease on a property that has been used by drug services expired this year. We've also lost use of the community hospital, which we'd used for a number of years, thanks to Dorset Healthcare, but they have other uses for that space now. And there's a number of service developments we'd like to see. So I'd like to see better integration with mental health. We've made some progress with that, but there's more to do. We'd like to see better mainstream health support for our clients. We are seeing an aging population who are being admitted to hospital with, for example, wound infections and then going on lengthy courses of antibiotics, and immune systems not in a great state. So the earlier we can intervene with those people through primary care, the better. So that's something we're working on. And general harm reduction, that's the kind of point of let's intervene nice and early if we can. So the next steps are really to, from my perspective, would be to extend that contract for the 2 years that we're allowed and to incorporate those key points in a service improvement plan. So that's the first point on the the kind of Dorset side. I don't know whether it's best to sort of just move straight on to the BCP side or take questions at that point on Dorset.
Should we do them separately? Because then I think that's more cohesive, isn't it? I don't know. I think we'll take the recommendations separately as well, because there are 2 recommendations, aren't there?
Yep.
Yeah. So does anybody have any questions on the Dorset Council and what Will's just talked about initially? Does anyone want to say anything about that or to ask him any questions? Well, we didn't have to take it separately. You can move on to the second part. Thank you.
Great. So by virtue really of the timing of the last recommissioning exercise, BCP is a little bit more complicated, because at that point we were slightly trying to anticipate exactly what the picture might be. So the one complication to the Dorset contract that I would point out is that we have a slight dogleg out into Christchurch of that contract. So really in substance misuse treatment, there are 2 kind of categories of treatment. There's talking therapies and there's prescribed medication. And traditionally, those have been, I mean, if we take before the public health reforms, those were commissioned separately. So the health service largely dealt with the prescribed medication side of things. So that's things like alcohol detox or maintenance prescribing for heroin use. And the local authorities, in our case, it could have been different partnerships, but ours were housed within the local authorities, dealt with the talking therapies. And in general, the history of that is NHS provider of prescribed medication, third sector provider of talking therapies. So those third sector providers would be organisations like EDP, EDAS, AdAction, as was now called We Are With You, those kind of organisations. The split of commissioning within BCP at that point was still that where the public health team had taken on for BCP across, at that point, the 2 councils of Bournemouth and Poole, the prescribing function. So Public Health Dorset commissioned the prescribing function, but the local authorities held the contracts for the psychosocial, the talking therapies. In 2017, the public health team took on that responsibility for the Poole contracts because they were expiring at the same time as the Dorset ones. They also recommissioned the prescribing service, but with a BCP footprint. So for BCP, we're nicely set, and it's nice and neat for the prescribing service. It covers the 3 areas of BC and P, and that's on the same contract. For the Poole talking therapies, again, the same thing. But what we have done is the Bournemouth talking therapies contracts are on a slightly different timeline, and there's still a team within what is now BCP Council who oversee those. So it's a little bit of a mixed bag there. What you effectively have is consistent prescribing support, but then slightly different models of talking therapy across the 3. And that Christchurch bit of talking therapy is technically under the wider Dorset Council contract for the full integrated service, if that makes sense. So obviously this poses us some challenges in terms of equity across the patch and also efficiency within BCP, because it's not necessarily fair or equitable to have those slightly different services. They also have slightly different funding per head. So obviously the vision across BCP is to harmonise that, and this is our kind of opportunity to do that. We now have a bit more clarity about where we are with the contracts and service performance. It's reasonably good, and we have made significant progress, particularly on the prescribing side, but there is the opportunity to look at that in the round, if you like. So you would want to keep on the table, as you review these services, the option of having a fully integrated service. There's lots of ways we could cut this cake, but you'd want to kind of leave that open. So the suggestion is that we conduct effectively that review over the next and award whatever is put in place within the next 12 months. So rather than taking up both years that we have available to us for these contracts, we just take up 1 year and use that 1 year to review what we've got in place and move towards a harmonised, hopefully more efficient service. So that's the proposal for BCP, is on those two contracts that we hold, so the pool talking therapies and the BCP prescribing, and also that little bit in Christchurch of the talking therapies through the REACH contract. We extend those just for the 1 year. There are no major concerns on those contracts that we hold, but as I say, there are those inequities that do need addressing, and there's areas, as with any service, where we could do better.
Okay, thank you. Well, that's helpful. I think Leslie, you would like to ask a question or speak, and I think Graham's raised issues around Weymouth and rural area support. So Leslie, should we go to you first with a question?
Thank you. Well, being from Christchurch myself, of course, when I hear the word harmonising, hackles up. But can you explain, it's not going to be harmonised downwards, is it? Because I always felt that our dear old Dorset, when we were in with you, I thought our service was slightly different, but can you just re-talk us through the harmonisation which you're aiming for? It's going to be as good as, if not better than, what we've got, is it? That's
essentially a decision that we'd have to take. So fundamentally, at the moment, what we have is 3, as I say, separate talking therapy services across B, C and P. They each have at least one base. So there is an EDP base in Christchurch, which they also use as their kind of office base for the wider sort of East Dorset work as well, which comes under the REACH contract. There's a base in Poole, and there's actually 2 properties in Bournemouth for slightly different bits of service delivery. I think as we go through the next, well, it would probably be 6 months, where you'd expect to have a clearer idea of what you want in place, that would inevitably be reviewed in terms of whether you would have 3 separate premises to operate out of. You could potentially have more, actually. But that would partly depend on the funding that's allocated to this. So we're still sort of, well, we are working to contracts that were set up prior to LGR, and there are differences in funding per head. And those differences in funding per head have probably become more acute as we have engaged more people in Bournemouth particularly. So there is something there in terms of a question of, have we got the spend for this service area right, and have we got the balance of that spend right across the different communities in BCP? I think those are key questions. I don't have the answers to that now, but I think it would be an important thing to raise through that kind of 6-month period. If you imagine that we were doing just a traditional procurement process on the same timeline as we did in 2017, we'd be pressing go on the procurement sometime in March, probably. That's what we did last time. Yep. So we'd have to have a very clear idea over the next sort of 6 months about that kind of funding envelope and the likely funding per head and the service design across the whole of BCP. I think it's very important. My personal view would be, if you looked at funding per head, you've got Poole is highest, and then probably Christchurch, and then Bournemouth. I think given the pressures we're seeing on the services in Bournemouth specifically, it would be very difficult to maintain a safe, effective service if you move to the funding per head of the Bournemouth services.
Right, thanks. I think that gives me some, well, comfort. And this is going to be going on in the next 6 months with who is going to be actually doing it?
That's a question for the board, hopefully, to decide in November. So I think at the next meeting, what I am assuming is that we'll come back with a kind of project plan,
right?
Particularly for BCP, obviously, but I think there are opportunities to do that for Dorset as well in a slightly different way. And at that point, I would expect a decision to be made about who would lead on that project, because at the moment we do have, as I said, and that there's all the classic strengths and weaknesses of wherever you house this and however you configure it.
Okay, that's great. Thanks a lot. Thank you, Chairman.
Thank you. I'm just going to go to Sandra first, because I think it's probably on the BCP side of things, and then I'll go to Graham if you want to raise something about the Dorset side of things. Councillor Moore, do you want to go for it?
Yeah, thank you, Chair. Yeah, definitely. Following on from Leslie, who looks after the Christchurch end. Obviously, I've been sort of used to looking after the Poole end, and it wasn't until fairly recently that I now appreciate how different the services are in the three towns. And having visited something in Bournemouth, actually in the Boscombe area. Totally impressed with the work that they were doing, but totally and utterly different service from anything that I'd seen in Poole. So I'm glad for this presentation and this paper, because now I'm beginning to understand, what's been happening and how everything was completely different. So yeah, I would welcome harmonisation. We can all sing from the same song sheet, which would be helpful. And yeah, the funding does need sorting out, because it's clear where the problems are. That's where the money needs to go. But thanks for this paper, because now all is revealed. Now I'm beginning to understand where I am and what I'm doing. So that's basically all I wanted to say. Apart from the fact in November, when we can see what's going on, that will be really, really helpful. So thanks for this. This is really good.
Thank you, Sandra. I agree, and it was always going to come out of LGR, wasn't it, that these things were going to need exploring and revisiting. And I think what these recommendations do is give us the chance to allow ourselves some breathing space to do that. Graham, did you want to touch on Weymouth?
I want to talk about, well, I don't want to, but I'm compelled to talk about Weymouth, because it is not only the jewel in our crown, it's also the thorn in our side and some things. Now, so this lease, what's happening there, Will? I don't quite understand that.
So this is kind of a legacy of, I think it was in 1990 that the NHS signed the lease, and then when local authorities took on some of the responsibility for drug and alcohol treatment, that transferred over to us, and we then transferred it over to EDP, who won the contract in in 2017 they won it, but they had previously held it as well. So the specific property that was referring to was no longer fit for purpose. But the issue at the time was that we were also losing use of the community hospital because Dorset Healthcare had other plans for that property. So initially, at the start of this contract in 2017, the service moved into the community hospital. So where previously just the NHS bit had been housed there, the third sector staff moved in as well. They also had previously had use of another property, because we had 4 different contracts across the old Dorset County Council area for different bits and bobs of the service, whereas we integrated those. So that was positive, but unfortunately couldn't last with Dorset Healthcare's decisions about providing other services from there. We have never resolved that, in terms of we've been using we've now got an admin base for the service, but we haven't got a kind of, if you like, shop front where we see service users, in contrast to, say, as we were just talking about, Christchurch, Bournemouth and Poole, where there is that kind of front door fixed base for treatment.
So it begs the question, why not?
It's been a challenge to find suitable premises, and the original plan was that at this point we would have had use of a building with use of a central government grant, PHE grant, but unfortunately we weren't able to identify somewhere that was kind of acceptable to all parties locally for that. Hopefully, and because we've obviously made this a priority for EDP, who hold the contract, it's top of the list in terms of finding somewhere that will work. We are, I don't want to kind of jinx it, but we are in a good position in terms of a current property search. Can we
have a conversation offline? Because with my other hat on with housing, I'm looking at setting up a 20-room hostel to try and permanently eradicate our homeless problem in Weymouth. And so perhaps we can have a conversation offline about something, because I'm thinking, okay, all very well having the hostel, but where does the wraparound care come from? So I think, can we maybe have a chat, Will, at some stage?
Yeah, definitely. And I particularly welcome that, in terms of, although I've said in this paper that we're looking at extending for 2 years in Dorset, I don't think that means that we sort of extend and forget about it. I think there's huge opportunities there in having that bit more breathing space to actually look at a more comprehensive, creative approach to this. So when we look at services, we currently commission substance misuse, housing support, mental health, and they are a little bit too separate for my liking.
They're absolutely two working their own silos, and that it's really important. I think I'd like to ask you to make it a priority to put a date in a diary where we portfolio holders and officers can have that conversation, because we need to work at pace. We should possibly be using this as our bid to MHCLG for funding for our homeless and rough sleepers. So there's a piece of work here that we should be doing. And just to touch on the reach service in rural areas, if I just alert you to the fact that I think it's a bit sketchy. It's a bit hit and miss. It's not as good. And I think we've got a lot of unseen problems in the rural areas, and it's flying under the radar, whereas in the conurbations it's right in your face, so we see it and we attend to it, and then we don't in rural areas. I'll leave that one with you.
If I can respond to that, just to say that our premises work, although it's obviously focused on Weymouth because that's where you could potentially get huge value from having a fixed base, without going back to the old days, we did used to have several of those kind of bases dotted around the county, so bases in Bridport, Blandford, Swanage and so on, and Gillingham. We don't have those anymore, with the exception of a sort of largely office base in Gillingham. And the challenge for us is, well, how are we delivering an effective, accessible service there? We can't necessarily have a Monday to Friday 9 to 5 presence in all those towns, but we need to have something that is accessible and available. And I think actually, without being too flippant about it, the current complete reshaping of how we've had to work because of COVID-19 does offer us some learning about how we can make services more accessible in the rural areas.
Yeah, I mean, if you live in Stoke Wake, Gillingham's not a lot of use to you.
No, we're definitely reviewing that property.
Thanks, well, and we'll look forward to speaking outside the meeting.
Great, thank you.
Thanks, Graham, and thanks, Will. I think that's a really good point, Graham, isn't it? Any opportunity that we can take to join services up and wrap them around has got to be a good thing. And I think the rural outreach stuff is something that's just an ongoing challenge and always will be. So I don't see any more hands up or any points to be made. So shall we move to the recommendations? The first recommendation is that the contract for the Reach service is extended for the full 2 years available to the end of October 22. And the second recommendation is that the contracts for services in BCP held by AWP and EDAS are extended for 1 year to the end of October 2021, with the expectation that a new service or services will be commissioned by either one of BCP Council or Public Health Dorset in the interim. So that brings those two recommendations bring everything into line and allow us to do that work. Members, are you content to take those two together, and are you content to support the recommendations?
Yes, thank you, Chairman.
Thank you. I'm going to take that as a resounding yes.
Yes.
Fantastic. Thank you all.
That appears to be unanimous.
Brilliant. Thanks, David. That's really helpful. So we can now move on to the approval request for Live Well Dorset Digital Services sourcing and commissioning. And I think what's popped up in the chat, something's popped up in the chat. Let's have a look. Yeah, I agree. Thanks, Sam. Sam's just popped up that was a good paper and useful discussion. Absolutely. And as I said, any opportunity to link services and link what we do and break down those silos is a really good thing. So Live Well Dorset, I think Sam's going to talk us through that, but essentially we're being asked to review and approve the sourcing plan that's been outlined, note the strategic context, objectives and shortlisting of the options, and delegate authority to Sam Leslie and I to award any contracts within the budget. Sam, do you want to just walk us through the background on this, please?
Thank you, Chair. I'm actually going to do a very, very brief introduction and then hand over to Sophia Callaghan, who's going to present the paper today, if that's okay. So just a very, very short context note. The Live Well Dorset service, some of you may be aware, is our in-house health improvement integrated provider. Partly this paper is a legacy of a decision that was taken when we took the service in-house. So it was previously commissioned out with a commercial provider, but we went through a process with the Joint Public Health Board to look at options for the future of the service and took it in-house as a directly provided public health service back in 2018, I believe. So this paper is just walking through where we are with some options for the future delivery of IT infrastructure, the customer relationship management software and the digital platform. So I'll hand over to Sophia.
Thanks, Sam. As Sam said, the paper, the reason it's coming to the board is that the contracts run out, they terminate on the 31st of March 2021. And the reason it's coming now, we want to keep business continuity and have time to mobilise and plan it. So the paper walks through an options appraisal, which is currently underway to consider how services will be sourced and delivered from April 2021. And we would like to undertake it now, as I say, because so we can ensure business continuity. The paper outlines elements of the service, which Sam's alluded to. These are in three areas: provision of IT equipment, infrastructure and support, the Live Well Dorset digital platform, and the Live Well Dorset customer relationship management system. There's a finance overview within the paper, which outlines all plans within existing budget. There's a strategic commitment element to ensure best value services for both Dorset and BCP councils. There's a long listing and a short listing process, quite a comprehensive process that's outlined in the paper. This is to assess whether we go in-house and or external providers, and we're in the middle of discussions with in-house providers on what can or can't be done. And if you see on the table, there's a pass-fail scenario going on, which really looks at feasibility in terms of timelines, business cases, timescale, business needs, and that sort of thing. So each element's been looked at, pass-fail, so that we can see which are the best options. So the most likely option at this stage would be to insource all the ICT provision and continue to procure digital platform and the CRM requirements, largely for timelines and effective mobilisation. So I'll pause there for questions before we move to the recommendations.
Brilliant, thanks, Sophia. I think, yeah, that's a really good paper, and I think we can all appreciate how brilliant Live Well Dorset is and how well talked about it is. I've used it myself to access park yoga, and I think it's great, isn't it? And I think anything we can do that keeps it sort of ticking along, especially when it's within budget, is a very good idea. Yeah. So thank you for presenting that. Does anybody have any comments or questions that they'd like to make? Seems quite straightforward to me and quite helpful. Thank you. Sorry, my son's just come in and thrown something in the sink halfway through there, which is really professional. But at least he's thrown it in the sink and not just left it somewhere. So yeah, I think it seems quite straightforward to me, and I'm happy to support. Does anyone have any comments? No, we're all content. Okay, so can we take the recommendations as I just outlined? I'll just scroll back to them quickly so we can just be confident that we know what we're approving. So just to review and approve the sourcing plan, which we've outlined and Sophia's helped talk us through, and delegate the authority to Sam and Leslie and I to award any contracts given that the sourcing plan providers and on the best terms achievable and within the budget. I think I love those words, within the budget. I think they're my favourite words. So if everybody's content, Leslie's just put in the chat box that she's happy to support this. Are other members happy to support? I'll take silence as a yes.
Yeah.
Thank you, Sandra. Thank you, Graham. Okay, so that's recommendations passed, both recommendations unanimously. David, thank you. And thank you, Sophia.
Yes, unanimous.
Very helpful report. Right, let's find my way back to the agenda, because I think that we are future of public health. Yeah, fantastic. Okay. Urgent items being the last item on the agenda. I'm not aware of any. David, are you going to tell me any different?
I'm not going to tell you any different.
You're not going to tell me any different. Fantastic. In that case, thank you everybody for turning up this morning, and thank you for really, really good discussions on this. I think November's going to be a really interesting meeting, and I always welcome the chance to really have a dig into these things. So thank you all. Thanks, Sandra, and I wish you all the very best for a nice day in the sunshine.
Yeah, thank you, Chairman. Thank you.
Thank you very much all, and I'd just like to say thank you to all those that have enabled this meeting to be successfully put on today. I had every confidence it would work, but it's good to see that it's been borne out in practice. So
absolutely, David. Yeah, thank you to the techies making it happen. Take care, everybody.
Bye.
Bye.
Bye-bye.